Good morning. I want to welcome you all to the 50th annual Kenny-Drash Memorial Lecture. When I was just putting these slides together, it really struck me, 50, wow, that's a very long time. And a little bit background on this named lectureship is for two very prominent endocrinologists who led the field and grew pediatric endocrinology, not only here in Pittsburgh, but all over the world. Dr. Frederick Kenny, he was director of pediatric endocrinology here in Pittsburgh from 1962 to 1975. He established the clinical endocrinology as well as the basic research program here at Children's and at UPMC. And for pediatric residents who are listening, that he described the Kenny-Caffey syndrome. You may have seen patients, and he was also the first to use cortisol secretion studies to establish normal adrenal function for children and adults. He was considered the Oslerian triple threat, the classic role model for integrating clinical responsibilities, mandate to teach at all levels, and continued inquiry into the mysteries of endocrinology. In 1975, he was succeeded in this role as Director of Pediatric Endocrinology by Dr. Alan Drash. And many of you may know Dr. Drash led the field of pediatric diabetes. He was the first in the world to differentiate type 1 versus type 2 and define insulin deficiency as the reason for type 1 diabetes. He developed the first insulin immunoassay in pediatrics, as well as diazoxide treatment for hyperinsulinism. Not just in clinical care and research, he also led the way in diabetes education. We always like to say this, like the world's first diabetes educator. The concept of diabetes educator originated right here at Children's Hospital of Pittsburgh. He was known as Mr. Pediatric Diabetes. He had the unique honor of being president of all three major societies, Pediatric Endocrine Society, American Diabetes Association, as well as ISPAD, which is the International Society of Pediatric and Adolescent Diabetes. I like to quote this when I think of Dr. Drash and his commitment to pediatric care. He wrote this letter to his daughter, Allison. And in me, I see this also as a parent explaining, somebody who's so busy at work, trying to explain to their kids like how important it is, and many of you can relate to that. He said, there's nothing more important to be consumed by a sense of dedication and responsibility to a calling into the service of others. And this line is what made me say the introduction. I could get by with doing far less than I do, but I love my work and the wonderful opportunity it has provided me. I'm excited every day when I get up and start to work because I know I'll be presented with new chances to advance knowledge and help others. So that's a kind of legacy and leadership they brought to pediatric endocrinology, and that continues. And you can see the legacy lives on. And I love this quote that says, it's not what we leave for people, material things, but what you leave in people, the same drive and the same dedication and commitment. As you can see in this picture, many of the prominent pediatric endocrinologists in the field today were all bestowed that legacy by Kenny and Dr. Drash, and they had the honor and privilege to work with them. You see Dr. Becker in the slide, in the black and white picture, Dr. Arslanian, Dr. Selma Mitchell, and the other person in the picture is Linda Seminario. She is the very first diabetes educator, as I mentioned, and she's still here with Pittsburgh, and she leads the Pediatric Diabetes Institute. So the legacy, their contribution and legacy has stayed on. And as you can see, and this is information, it's always helpful to write T32 for those of you who may not think so, put together the history, and it was really fascinating to see 4 presidents of the Pediatric Endocrine Society, 7 chairs of the Department of Pediatrics, 26 chiefs of pediatric endocrinology, and 6 center directors were all trained in CHP pediatric endocrinology. So it's an immense honor and a source of pride. So continuing along this legacy, we are so excited to have Dr. David Allen as the 50th annual Kenny-Drash Lecturer. So Dr. Allen did his undergrad at Stanford and his MD at Duke before becoming a lifelong Wisconsinite. I hope I say that right. That's what I heard yesterday. He did his residency, chief residency, and fellowship at University of Wisconsin. joined the faculty and rose through the ranks, and he is now professor with tenure. He is the chief of Division of Pediatric Endocrinology, as well as program director of the Pediatric Endocrinology and Diabetes Fellowship, and PI of their T32. Dr. Allen's journey has been illustrious. His interest has been primarily growth and research, and clinical interest has been growth and growth disorders, but he's also published a lot on ethics in endocrinology. He's published more than 200 original articles, textbook chapters. His CV is very long. Just summarizing it, numerous visiting professorships, numerous grants, including the T32. He's been a leader in the field, has held many professional roles and leadership in many societies. He was, as I mentioned, president of the Pediatric Endocrine Society. He is now chair of the Pediatric Endocrine Society Specialty Workforce Task Force. I think it's one of the most important jobs to leave the legacy to continue training pediatric endocrinology. He has been involved in the organization of many national and international meetings, and he's also been the chair of the PES Strategic Task Force. He's won numerous awards in his career, and this year he was selected for the 2025 Judson Van Wyck Prize from Pediatric Endocrine Society. This is the top honor awarded by our society to an outstanding leader whose career is marked by scientific excellence, leadership, and dedication to the health of children. I also learned that he's a member, board member of the Wisconsin Chamber Orchestra, and he loves his piano. Looking back on his career, I have no doubt, and you will agree with me, that he's an ideal candidate for this lectureship. His career highlights his dedication to the field, dedication to training the next generation of pediatric endocrinology, the same legacy and vision shared by Drs. Kenny and Drash. So it's my pleasure to invite Dr. Allen to talk. And
Thank you. Thank you so much for that lovely introduction. It's such a pleasure and an honor to be here to give this lecture. I did have the pleasure of knowing Dr. Drash a bit very early in my career, and I just remember how much respect he had in his field, and also how people just really loved him as a human being. So it's really special to be here to give this 50th lecture. I will advance here and begin this lecture, which is a story. I mean, at this point in one's career, almost every lecture you give is a story that spans, whatever, 30 or 40 years. And I really like talking about this topic also because it really takes me back to the days when I was a fellow. And as I say, after all these years, this is still an issue that confronts us in pediatric endocrinology, and which I think is important to have some expertise. Here's the objectives of what I want to cover today, and I really hope to do this in a way that's very relevant for everybody in general pediatrics as well as the consultants, and do it in a way that also provides a sense of perspective about what the benefits and the burdens of this treatment are, because I think that's a big challenge when using glucocorticoids for treatment. So we'll review why it is that glucocorticoids are such potent growth suppressors. We'll review some of the interesting properties of different inhaled corticosteroids that create risk for systemic effects. One of the things I really like to focus on is what's different about each individual child that creates variations in their risk to side effects from inhaled steroids. And then we'll talk about some strategies to minimize these effects and how to talk to families about how to use these medications safely. So as I mentioned, every good lecture starts out with a good story, and this was my story. When I was a fellow, this was like 1986 or so, this young lady came into our practice, and with the complaint of really complete growth suppression over the prior 10 months. She had her asthma diagnosed the prior year and was being treated with inhaled corticosteroids in the form of triamcinolone. Now, this was the beginning of inhaled corticosteroid treatment. It was really in the mid-'80s when these medications became available and became first-line treatment for asthma. So she was doing very well with her asthma, very well controlled, but there was no change in her inhaled corticosteroid dose. We suspected, based on her physical exam, that she was experiencing cortisol excess. We did some other studies that showed that her adrenal axis was also very suppressed. We worked with a primary care physician to lower the dose of inhaled corticosteroids. And, 6 months later, she came back and she was growing in a very different person. And this was the first, the author in this paper, Greg Holman, he was one of our residents. So I was a fellow. We wrote this up and published it in Pediatrics. It was the first description of growth failure related to inhaled corticosteroid use. And it's hard to imagine this, but the idea back then was that these were completely safe medications, that they were entirely topical, and that they had really no systemic effects. And so this was really noteworthy and really got people's attention that possibly there could be systemic effects from these steroids. Well, why does this happen? Well, it's a complicated diagram here of all the ways that cortisol or glucocorticoids can affect the growth axis. And one way to kind of think about it in general is that these two systems, the growth system and the stress system, are really at odds of each other. And it makes some sense teleologically. During periods of high stress, the body doesn't want to be directing a lot of energy toward the growth process and vice versa. When we think about glucocorticoids in particular, we can start over here with the secretion of growth hormone, which is controlled by this balance between stimulatory growth hormone releasing hormone and inhibitory somatostatin effects from the hypothalamus to the pituitary. Glucocorticoids heighten the somatostatin tone, so diminish the overall growth hormone secretion that's happening. And we see downstream with decreased growth hormone effects, we have decreased IGF-1 production by the liver, we have decreased growth hormone effects at the growth plate itself, and we have decreased connective tissue growth related to diminished growth hormone secretion. But on the other side of the diagram, we also see that glucocorticoids themselves inhibit the growth axis at just about every place we can look. They decrease the growth hormone receptor expression in the liver. They have a lot of direct effect in the growth plates, which limit chondrocyte expansion and promote apoptosis within the growth plate. And of course, you can imagine if there's going to be any effect from adrenal steroids like adrenal androgens contributing to the growth, that can also be inhibited. So these combined effects are the reasons why glucocorticoids are such potent inhibitors of the growth process. And when it comes to inhaled corticosteroids, one of the most important things to remember is that they're extraordinarily potent glucocorticoids. What this figure demonstrates is that compared to the binding affinity of dexamethasone here, which would be 100, these molecules are extremely potent, 10 to 15 times as potent as dexamethasone at binding to the glucocorticoid receptor. So here's the picture that is perhaps maybe the most important in the whole lecture from a sort of physiology standpoint. And that is, what happens to these inhaled steroids after they're inhaled by a child from the device? And we have a distribution of some of the medication getting delivered to the lung and some getting swallowed. And of course, parameters such as technique and device affect the distribution of medication to the lung or to the GI tract. But one of the misconceptions early on was that the medication that was distributed to the lung was not going to be systemically absorbed. Well, we eventually learned that that was completely wrong. And essentially all the drug that gets delivered to the lung gets into the systemic circulation. So the important corollary there is that the more drug that gets into the lung, the more drug gets into the body. Now, of course, the advantage there is that it's very targeted. That's where we want the medication to be. But it has to be remembered that everything that gets to the lung gets into the systemic circulation. What about the swallowed portion? Well, this is where there's lots of variability. Because depending on the particular inhaled corticosteroid, you can have anywhere from 10 to 50% oral or I should say from 0 or 1% to 50% oral bioavailability of the swallowed portion of the drug, okay? So for some of the inhaled corticosteroids, it really doesn't matter how much of the drug you swallow. For others, it's very important. And this is one of the key determinants about the risk for systemic effects from particular inhaled corticosteroids, which we'll see subsequently. So it's the addition of both the medication that's getting into the lung and the medication that's getting swallowed, how much of that gets into the blood, that creates the risk of systemic side effects for a child. So with the awareness that these medications could possibly have systemic effects, and particularly on growth, The FDA then became very interested in requiring that every new inhaled corticosteroid had growth studies to demonstrate its safety. So I was brought on as a consultant for the FDA to help them design or set up requirements for growth studies. And it turns out, I mean, this is like really complicated to set up studies that are going to determine whether a medication has a particular effect on childhood growth. And some of the things that you have to take into consideration is, first of all, you have to know, well, how are the children growing before you do the study? So you have to enroll people actually for several months before you begin studying the medication. We have to have at least enough time to cover the seasonal variations in growth. So every growth study has to be about a year in length at least. And that what we're doing is we have to compare then the growth rates of the children before this study period to what happens during that time. And we have to do that in using a parameter called the growth velocity standard deviation score. Because if you, as you'll see with growth velocity curves, even from one year to the next, the expectation for how fast a child is going to grow is going to be different. So you really have to be taking that into account. So it gets quite complicated. And so what we're doing with these intervention studies is really comparing the baseline growth velocity and the expectation then for growth over the subsequent 12 months on and off the medication. So these standards became the guidelines for growth studies for all the inhaled corticosteroids that the FDA has used, and they're still using these requirements for growth studies. So with those parameters in mind, there were three major studies that were done during the 1990s to really look at this question about growth suppression. One looked at beclomethasone and showed fairly clearly that the standard dose of beclomethasone, 200 micrograms twice a day, caused a 1.5 centimeter difference in growth rate expected. So that's about a 25% reduction in growth rate. Most children are growing about 6 centimeters per year during their school age years. Then we did a study using a fluticasone, which is a bit different from beclomethasone in terms of how much drug is of the swallowed drug is absorbed. And we showed there was a detectable growth effect, but it was only about a third of what you saw with the beclomethasone on a roughly equal clinically equivalent dose. And then there was a longer term study looking at budesonide, which is Pulmicort, which again showed that the growth could be slowed during the first year, about similar to the beclomethasone. But when they followed the kids out for several years, it looked like most of the growth suppression was confined to the first year. And then after that, there was sort of like escape from the growth suppression. So maybe the height outcomes were going to be fine. So that led to, by the year 2000, there was a certain conventional wisdom about the systemic effects of inhaled corticosteroids on growth. That was, there was a dose-dependent slowing of growth that you could document, especially in prepubertal children, that it was more pronounced in those inhaled corticosteroids that had significant oral bioavailability of the swallowed drug. We really didn't know about what would happen to younger children and to older children. The assumption was these are periods of time when kids are growing very rapidly, either when they're very young or when they're in adolescence. And the idea was, well, the growth system was probably a little bit more resilient to growth suppression during that time, but we didn't know. But that was the assumption. From that Pulmicort study, it seemed like maybe these growth effects were very front-loaded so that we didn't need to worry so much about big changes in the adult height attainment. And that the expectation was, since most of the side effects were seen in drugs that had systemic oral bioavailability, that this would become less of an issue as the medical profession moved away from those medications into what were safer ones. In other words, medications, fluticasone, mometasone, ciclesonide, that didn't have much absorption at all from the GI tract. Around the same time, everybody might remember this, there was this remarkable multinational collaboration to reduce the use of chlorofluorocarbons in medications because it was having this adverse effect on the ozone layer. And the Montreal Protocol from the early 1990s was coming into effect. It gave nations 20 years to basically eliminate the use of these CFCs. And it was remarkably effective. You can see here the declining use of CFCs over the 20 years after the Montreal Protocol. This is showing that after about 2000, we started to see some recovery in the ozone amount in the atmosphere, which is now projected to continue if we do this. So this was remarkably effective. So this had a major effect on inhaled corticosteroids, which up until that time were all using CFC as a propellant. And they had to then make a change to different ways of propelling their medication. Well, for about 15 years, I wasn't seeing many children in the clinic coming with this complaint. And then around 2013, 14, 15, we started seeing children come back to the endocrine clinic with clear evidence of growth suppression by inhaled corticosteroids. And here's an example of a child that we saw who was being treated with dry powder inhaled corticosteroid for a number of years after asthma was diagnosed. At this point, at the age of 6 or so, the dry powder was switched to what was HFA, hydrofluoroalkyl propellant inhaler, and we started to see this growth suppression. And then around the age of 8, ADHD was diagnosed, and I think it was Ritalin was added to the medication, and the growth velocity slowed. In fact, it almost stopped by that time. And then at this point, we saw him in the clinic. We suspected at least that the inhaled corticosteroids had something to do with this, switched him back to the dry powder inhaler, or his pulmonologist did, and the growth resumed. We thought this was quite interesting for a couple of reasons. One was what was going on with the inhaled corticosteroids that was so different between the HFA and the dry powder. And the second question was, did the addition of another medication like Ritalin just compound the effect of the inhaled corticosteroid on growth suppression? And was this going to be a reason why these children were going to start to present to our clinics again? Well, when it comes to the difference between CFC inhalers and HFA inhalers, it turns out that the biggest difference is in the particle size of the molecule that's being delivered. And this has an exponential effect on how much of the drug actually gets from the delivery device into the lungs. And so you remember now, the more the drug that's getting into the lungs is getting into the systemic circulation. And I think the most illustrative part of this table is to compare the CFC beclomethasone here, the older model. Here's the particle size, 3.5 microns. Here's the HFA, only about 3 times smaller. And you can see the difference in lung deposition here. 8% of the delivered dose in the old inhaler, 56% in the new inhaler. So a dramatic difference in the amount of medication from the same dose going from the inhaler to the lung and then into the body. So how did this put together? So this prompted me to write this review back in 2015. And I just have to thank again the artist in our department that helped me with this diagram, which is complicated, but it's one that I still love. And so what this does is sort of model out an idealized situation of a child taking different inhaled corticosteroids, 100 micrograms from their inhaler, and what the destination is of the drug after that. And let's just take a look. These two outside examples are comparing the beclomethasone HFA to the CFC. And as we see from, in that case, only 8 micrograms of the inhaled gets into the lungs compared to 56 micrograms from the inhaled, from the HFA inhaler. The swallowed portion, then, we have 92 micrograms from the CFC and 44 micrograms from the HFA. And one of the things about beclomethasone is that there's about 50% oral bioavailability of the swallowed drug, okay? So that's why even of the swallowed drug, we have another 23 micrograms from the HFA inhaler and 11 micrograms from the CFC, giving us a net out of that 100 micrograms that's delivered from the dose. 67 micrograms of the beclomethasone appears in the child's systemic circulation, beyond the lungs, capable of creating some systemic effects. You can compare that then to, for instance, fluticasone. The dry powder inhaler actually was a very inefficient way of delivering fluticasone to the lungs, which was good from a side effect standpoint. We didn't see many side effects. You can see only 8 micrograms then gets into the lungs, 8 micrograms gets into the body. But in this case, even though you swallow 92 micrograms of the dry powder, none of it gets into the systemic circulation. Okay, so the net effect of dry powder fluticasone is that out of 100 micrograms delivered from the inhaler, only 8 micrograms gets into the bloodstream. Now that was doubled with the use of the more modern inhaler from an HF to an HFA fluticasone. So still, the point is being that to get the same clinical effect with the deposition to the lung, medication dosages had to be reduced by 50% to avoid the side effects and the growth suppression effects. So that led to this analysis of, well, what were some of the assumptions we had from the year 2000 and how do they need now to be adjusted in the new era of new inhalers and the way these drugs are being delivered? And one was that, well, the better we got at delivering the drug to the lung, the fewer side effects we would have because most of the side effects were related to swallowed drug. Well, it turns out that really wasn't the case. And this very interesting study, I thought, was using the inhaled beclomethasone with the HFA inhaler on very modest doses, 44 micrograms twice a day or 40 micrograms twice a day in this population. And they showed in this group of school-age children, there was still a demonstrable decrease in growth rate of about 1 centimeter per year, even with this very low dose of inhaled corticosteroid. Now, this was very tightly controlled, so the compliance was perfect in this study group, which is going to be a very important point when we come talk about the risks, individual risks later on. But clearly, a drug like beclomethasone, which has a lot of effects from the swallowed drug, can have an effect on growth at very low dosages. So the point now is, well, we're in a new era, and that the increased delivery of inhaled corticosteroids to the small airways using these new delivery devices increases inhaled corticosteroid delivery to the systemic circulation. And unless we titrate the doses down accordingly, we're going to see more systemic effects. That raised the second question then about, well, which children would be at risk? As I mentioned before, all the FDA studies from the 1990s had been focused on children from the ages of 5 to 8 because we didn't want to have to be confused by the pubertal growth spurt or by very early deceleration in growth, which happens during the first 3 years of life. But now we're wondering about, well, what about the young kids or the older kids? And for those of you that don't work with growth velocity curves very much, I just want to illustrate to you here how differently childhood growth looks when you're looking at a growth velocity curve compared to when you're looking at a height versus age curve. You can see the tremendous variability that's happening with the growth axis in children when they're very young and growing at extremely rapid rates or when they undergo their pubertal growth spurt. So these are very dynamic times that are very difficult to study. But we did do this in the early 2000s with this very large cohort of toddlers. And the idea behind this study from the pulmonology standpoint was they were really looking at whether they could prevent later childhood asthma with really early intervention with inhaled corticosteroids. With that idea, there was a theory about airway remodeling that was quite prevalent. It didn't actually turn out to be true or valid, but that was the idea about early intervention. So we had this large cohort of toddlers who'd been treated very consistently with a very modest dose of inhaled corticosteroid. And what we showed here, these two that I want you to look at, this is in the lighter kids, greater and less than 15 kilograms. And in this lighter children, there was clear decline in growth velocity. And interestingly, in this white area, this is the time that's after the drug exposure. So they did not show an increase in their growth rate after they were off the inhaled corticosteroid during the trial. And also the younger kids showed more growth suppression than those that were a little bit older. These are 2-year-olds and these are the 3-year-olds. So it was an interesting finding, but pretty clearly showed that in spite of the fact that children at this age are growing pretty darn fast, you can still slow their growth down by exposure to exogenous glucocorticoids. So we had to kind of now amend our prior assumptions and add to that, well, it looks like even toddlers can experience slowed growth related to exposure to inhaled corticosteroids. And then this case that we published also raised a very interesting additional question that we hadn't thought about 20 years ago, 30 years ago now. And that was that we're seeing more and more children on multiple kinds of medications. And what are the effects? What are the added effects of multiple types of potentially growth inhibiting medications? And this is an important consideration in a number of situations. For instance, many children that have severe allergies are on both inhaled and intranasal corticosteroids. And just like with the inhaled steroids, there are quite a bit of difference between the products. The same thing goes with intranasal steroids. So some of them have fairly significant absorption into the systemic circulation after administration. For instance, like Rhinocort, which is budesonide, that has fairly significant absorption through the nasal mucosa compared to Nasonex or Flonase, fluticasone or romidazole, which has very low bioavailability when given in the nose. So those have to be considered, and they can add to the systemic burden. Another route that we've been seeing increasingly with the diagnosis of eosinophilic esophagitis is the use of swallowed inhaled corticosteroids. And again, the same thing sort of applies. Some of those preparations will have oral bioavailability. The others will not be absorbed very much at all. So that's another consideration. And then this very interesting and common situation of all the children that are being treated with CNS, what I now call CNS acting medications, most commonly stimulants, which I can't keep up with the statistic. Every time I check the statistic, there's more and more estimates of how many millions of our children are on these medications. But it's been demonstrated in a number of studies that they have inhibitory effects on a lot of endocrine systems, including growth hormone secretion and so on and so forth. And also the antidepressants or the anxiolytics. So this is, to me, the biggest challenge for the next era of pediatric endocrinologists to try to figure out how are all the ways that these medications are interfering with our growth axes, our puberty axes, because we clearly see this. I'm sure the endocrinologists in the audience understand what I'm talking about these kids appearing. And here's just a growth velocity chart of that child I was showing earlier, showing that, with the addition of the stimulant to the inhaled corticosteroid, we saw like a compounding of the growth slowing effect. And so what kinds of studies, what information is available out there? Well, there's quite a bit of literature looking at methylphenidate effects on growth. There's some observational studies that suggest that height is inversely related to cumulant stimulant dosage exposure. There are some prospective studies that have shown kind of an expected growth or a growth rate slowing of about 0.5 to 1 centimeter per year during treatment. And one important point I want to make about this is this does not have anything to do with what's going on with the weight curve. Okay, these effects on linear growth are distinct from problems with gaining weight. Okay, so they're not really correlated with each other. And then some of the better studies, like this prospective sibling control one, which was quite interesting from a few years ago, comparing children that were treated to their siblings at similar ages, and showed, again, this difference in growth rate, about 1 centimeter to 1.5 centimeters reduction in growth rate. And I just had to show this curve because I am seeing so many of these children. And just last week, here's an example of a child I saw. I had to put his growth curve into this talk, but it's very illustrative. Growing right up along here on the growth curve, fairly close to the midparental height prediction, and then began stimulant medication about this age, and then I think he had guanfacine added somewhere in here, and you can see, the growth rate is just really, really slow. And then we're also seeing pubertal suppression, suppression of pubertal onset in this youngster. So I think the key message today is that, these commonly used medications that also have growth inhibiting potential can have a compounding effect when used in conjunction with inhaled corticosteroids. And so these are children that are at high risk, I think, of experiencing the systemic effect. And then what do we know about adolescence and adult height attainment? Because maybe, the introduction to this paper from 2015 was my own story. I grew up with really severe asthma. In fact, some of my vivid memories as a child was my pediatrician father coming home from the office to give me an epinephrine shot on the front lawn after I had, walked out on a fall day and gotten exposure to something. And the question was, well, okay, would I have traded, a centimeter in height to have better control of my asthma? If that's really what we're talking about, maybe we shouldn't be worrying about this. And so this question about, well, do any of these effects on growth really persist and translate into kind of any clinically meaningful concern about height gain in the end? And the first study that really looked at this was a follow-up of that original 4-year budesonide study. And they actually, out of 1,000 children that were in that study, they were able to find like 950 of them and measure their adult height. And they showed that it was only about a centimeter less than expected. So seemed to be quite reassuring that even if these effects occurred during childhood, they were largely alleviated during the adolescent growth spurt. And so, I mean, it showed there was some effect, but it seemed to be quite small. But they acknowledged the problem here was it was an observational study. And so we really didn't know about adherence during these years and whether children were even taking their inhaled corticosteroids anymore. In other words, it didn't answer the question about whether a person with significant enough asthma and good enough patient compliance that they were consistently taking inhaled corticosteroids during their teenage years would that have an effect on growth. And a subsequent study then was quite interesting in this regard because it really did look at this issue of consistent administration during adolescence. And it showed there was a fairly clear decline in both boys and girls in the height SDS in the inhaled corticosteroid treated children. So it stands to reason that you can inhibit growth at any time with exposure to these medications. If the adherence and the consistency of administration is strong enough. And I think this is also a really important question to be answered when it comes to some of these other medications that we're talking about, the CNS acting medications, whether they are going to have an effect of blunting some of the acceleration of pubertal growth that happens. Again, it's all a balance between benefits and burdens. So I'm not suggesting that these medications are not valuable. They are. It's just something that has to be put into the equation. So I think this perception about no effect at all on adult height needs to be modified slightly because it looks like we probably can see some growth attenuation during adolescence with really consistent exposure to inhaled corticosteroids. I wanted to add this in because I thought people might be interested. It's like, well, what could you do about this? If somebody really needs treatment with these inhaled corticosteroids persistently and they're experiencing growth suppression, is our only recourse to kind of like trade asthma control for the growth question? And this is an old study, but I was very interested in this question about glucocorticoids and growth back in the 1990s after I was involved in this area. And one of the studies that we did, this was a national cooperative growth study cohort, and it showed, that growth hormone treatment could reverse the growth suppression from glucocorticoids in most children. And it makes some sense because one of the reasons that kids are experiencing growth suppression is all those aspects I showed you of the growth hormone axis. And so this was a study, and you can look at the asthma population, growing quite slowly here before treatment with growth hormone. And even for 1 and 2 years afterwards, there was restoration of a normal growth rate with growth hormone treatment. Unfortunately, this was never picked up by the pharmaceutical industry as a indication, to try to push for this. So to this day, this is not an indication that we can use growth hormone treatment for. But I have some examples where I have used it, and I just wanted to show you this one example of a child who, I followed for a few years with really profound growth suppression. And then, finally, I think we probably did a growth hormone stimulation test on him, and he scored low enough to qualify or what have you, and, began treatment with growth hormone, and this is his response. So there are some things that can be done, but in our current situation, it's very difficult to accomplish these sometimes with the insurance climate. Well, before closing, I wanted to touch on the topic also of adrenal axis suppression, which is, of course, the side effect from glucocorticoid treatment that everybody is most concerned about. And I will say that when, I began this journey back in the early 90s, the assumption was sort of, well, monitoring growth very carefully would allow you to know whether a child was at risk for adrenal suppression. Sort of like, well, the growth is going to be the most kind of sensitive and continuous indicator of glucocorticoid exposure. So we probably don't need to worry about adrenal insufficiency if a child continues to grow normally on their inhaled corticosteroid dosage. But then we had a case in the early 1990s of a child that presented to the emergency room with hypoglycemia, low cortisol levels, adrenal crisis, and had not experienced growth suppression. I mean, there were some other complicating things with regard to prednisone exposure and so on and so forth. But the point was that this was the first case that was reported of adrenal insufficiency resulting from exposure to inhaled corticosteroids. And this child did not have growth failure as a harbinger, as a warning. Why does this happen? Well, we know the normal feedback loop. Of course, in normal physiology is that cortisol production feeds back on at the pituitary and hypothalamic level to decrease the stimulation of the pituitary gland to make adrenal corticoid ACTH and stimulate cortisol production. And the addition of any exogenous glucocorticoid is going to diminish that production in a proportionate amount. Okay, so, and this is well demonstrated in this study. This is a fairly recent study just showing the cortisol, the average cortisol levels on this red line of individuals taking inhaled corticosteroid treatment versus those that are not, these top lines of the control population. And so any glucocorticoid that gets into the systemic circulation will proportionally suppress our own production. Now, that doesn't mean we're at risk for adrenal insufficiency. That has to be long enough and it has to be of sufficient magnitude to really diminish your central nervous system from reacting and being able to produce CRH and ACTH. But it does show you that these drugs are getting into the systemic circulation and substituting to some degree for endogenous cortisol production. So as is the case with glucocorticoid treatment in general, the higher the dose, the longer the duration, the greater the risk for adrenal insufficiency. So how do we know when a child's at risk for this? Well, this is a figure that I dragged out from a paper from way long ago, but it does show, if anything's even more complicated to study than the growth system, it's the adrenal axis, trying to determine when a child's at risk for adrenal insufficiency. We have all these different kinds of tests, some of which are extraordinarily sensitive to telling us when glucocorticoid is present in the bloodstream, for instance, like collecting 24-hour urine on a person and looking at their free cortisol excretion. You know, any of us, if we took 5 milligrams of hydrocortisone at night and we followed our free cortisol excretion, we would see a diminution because it's substituting for our endogenous production. That doesn't mean we're at risk for adrenal insufficiency. So where's the, you know, so we have other tests that tell us when the axis is being more dynamically suppressed. But of course, practitioners are interested in what can I do in day-to-day life that will help me to know whether a child's at risk. And I think that's where we still come back to a fairly simple assessment of what's going on in the morning when the HPA axis, the adrenal axis, should be fairly active. And that's looking at AM plasma cortisols. And nowadays we have the advantage, which we didn't 20 years ago, of looking at ACTH levels, which can also be kind of handy as a way of indicating how suppressed the system might be. So how does this translate into some real life recommendations? Well, as I mentioned, we can't rely on growth failure as an indicator of risk for adrenal insufficiency. I think that's been well documented at this point. And one important point is that if children are getting exposure to oral corticosteroids for exacerbations, ongoing exposure to inhaled corticosteroids after that will dramatically slow how fast their HPA axis recovers, because again, they're getting exposure to exogenous glucocorticoids from their inhaled corticosteroids. But here's some fairly, I think, straightforward and somewhat useful guidelines, and that is, you know, when we have children that are at risk, either because they're showing some signs or because they're on higher dose treatment or because they're getting corticosteroid exposure from multiple sites, an AM cortisol that's clearly low probably should be referred for counseling and treatment for adrenal insufficiency. What about in this borderline range, somewhere 3 to 10? Well, the low dose ACTH stimulation test is helpful in that regard. Again, these guidelines are somewhat arbitrary, but if anything's less than 18 or 20, you might be concerned about presumed or provisional adrenal insufficiency. And if the AM cortisol is greater than 10, not so much of a worry. Again, there's nothing hard and fast about these rules. They're always exceptions, but I think these are relatively helpful in the primary care setting about thinking about when to think about this risk. And when we do suspect that a child's at risk, what are the important things that we should do in terms of counseling? Well, one is that during illnesses that happen that are not going to be requiring a doubling or a tripling of their inhaled corticosteroid dose, like for non-pulmonary illnesses, it's important to supplement with what we call stress dose Cortif. So we provide these families with a hydrocortisone prescription that when the child's having a febrile illness from strep throat or a vomiting illness or something like that, they can use stress dose oral steroids. When they're having a pulmonary exacerbation or a rough time with their asthma and they're tripling their dose of inhaled corticosteroids, it's probably not so necessary, right, to supplement with oral corticosteroids. So there's a balance there. So these are really with non-pulmonary illnesses. Perhaps most importantly, though, this is the one I really emphasize, and that is what you're really worried about with these children is that they're going to be in a car accident or they're going to get a severe illness or they're going to wind up in the emergency room and somebody's not going to know that they're at risk for adrenal insufficiency. So perhaps the most important thing that you can do when a child is at risk for these kinds of episodes is to have them wear a medical alert bracelet that identifies them as a cortisol dependent person for those kinds of emergencies. Obviously, consultation with your friendly endocrinologist, I think, can be helpful in these situations. So let's finish up here with just what I call some suggestions for informed discussions about the use of these medications, because families are concerned about the growth of their children. That's one of the things they're most concerned about. And when they go online and they read about a medication you prescribed, many times there's unrealistic concerns then about the growth effects of these medications that lead to poor compliance. And again, that's not helpful. And we really want to have the asthma to be in good control. So one is to reinforce that the diagnosis of asthma and dealing with asthma can be a serious situation. And the number one priority is good control of the asthma for this child. And with the prescription of this medication, we need to talk about, okay, this is a very effective medication. It continues to be the most effective medication now 40 years down the road, but there are some potential side effects that we just have to be mindful of. But it's so effective, it's definitely worth your child being treated with it. And we can reassure the family that we can monitor for these side effects. We can measure the growth every 4 to 6 months. And we can, if we're having to use high doses, we can do some blood tests to see whether or not there's any other risks to be worried about. And with proper drug selection, and I think I've given some guidelines here about picking drugs that have very low oral bioavailability is probably the safest way to do it. And then titrating to the lowest effective dose, like we do with every kind of glucocorticoid treatment. And that requires seeing the child back. If things are going well, making an attempt to reduce that dose to get down to the lowest effective dose. With these very efficient inhalers, most of these children do very, very well on extremely low doses of inhaled corticosteroids if they take them consistently. And what kinds of kids do we worry about, and especially? Well, obviously those that are requiring the higher dosages. There are some children that seem to be at greater risk. This is just my own personal opinion. I don't have a study that proves this, but there are differences in children in terms of the resilience of their growth axis to insults, whether it's stimulant medication, whether it's inhaled corticosteroids. And my experience has been that those children who are already short-statured or experiencing growth delay related to constitutional growth delay are a little bit more susceptible to growth inhibition than those kids that are already tall-statured and not experiencing any growth delay. We talked about keeping an eye out for other medications that also might be suppressing growth. And the greatest risk factor, of course, of all is these families that are very compliant. I mean, it is the highly compliant family that never misses a dose of the inhaled corticosteroids that are at high risk for these adverse effects, these effects we don't want. At the same time, these are the families that can almost always be reduced to a low dose of inhaled corticosteroid or steroid exposure. So just be on the lookout for those families that are very, very compliant. So with that, I want to thank you again for this wonderful opportunity to honor Dr. Drash, Dr. Kenny, and for meeting all these people at this institution, and happy to entertain any questions if you have some.